governing compounding, please come on up and sign in so we'll know that you're here to do that. And in fact, I'll have this in my hand over here since I need to make sure everybody's called up and comes. But if you hadn't signed up, come on up and do that and give you a chance to address it.
I apologize for the lateness. We'll get started here in just a few minutes.
Check the weight before you leave.
I already told her. I've already started cutting down.
After he left, and of course Lisa's taken over after we promoted Crystal up to assistant director. And so far, they've been working out very well and very glad to have them on.
Okay.
And I do want to publicly acknowledge Josh and Ellen and Crystal, who have done an exceptional job of finding candidates. We've had to do that a little more often than we'd like typically. Yep. And we do, of course, I think everybody knows that Nathan has gone to the FBI Academy, and that's why he's no longer with us. So welcome to you both. Lisa at least got thrown into the deep end of the pool at Wendy's 15th year, so she's seen who we are, and she's still here today. So we got that going for us, I guess.
Well, Lisa Maria, welcome to our family. I extend a welcome from other board members. We have a sign-up sheet floating around this room and the overflow. If you'll make sure you sign in before the day is out, we appreciate it. And Mr. Campbell, I'll turn it over to you, please.
Thank you, Mr. President. As you know, we have scheduled today a public hearing on proposed repeals and amendments to rules governing compounding. If I could just give a couple of things. We are proposing to repeal certain rules in the North Carolina Administrative Code and amend certain others governing the practice of pharmacy compounding. The rules are designed to do two things primarily. Number one is to make sure that North Carolina rules governing compounding are harmonized with new federal compounding requirements imposed by the Drug Quality and Security Act. And number two, to consolidate and simplify the rules under one section instead of having them sort of staggered over a number of those. The rules were published. We have public hearings to hear comments on proposed rules. That is the purpose of today's meeting. We do have 6 folks who have signed up and indicated they wish to speak to the rule. Those who are speaking to the rule, there will be a 5-minute time frame to speak to the rule, and at the chair's pleasure, if you still have further comments, and it's the chair's pleasure, you can certainly speak for longer than that. I think Chris prepared a 30-minute speech. Is that right? So we look forward to that, Chris. But with that then, I will, and I should make sure everybody knows, for those of you who are making public comments, just be aware that we do live stream our meetings. And so your comments are going out over the interwebs to the probably 10 or so people that over the internet. However, they are archived. So
8 of whom we're looking for cat videos.
So with that, then I will proceed down the list as it has been, as folks have signed up. And Bob Carter is here from Carolinas Healthcare System. Bob, come on up. And if you would, as you're coming up to speak, you sit in the hot catbird seat there, and be sure you just, if you would, Bob, I just introduced you. If you would, state your name and who you're with for the record, and then the mic is yours.
Well, thank you. My name is Bob Carter. I'm the Vice President of Pharmacy Services for Carolinas Healthcare System. Our flagship hospital is Carolinas Medical Center. We're based in Charlotte. Carolinas Healthcare System, we represent over 40-plus hospitals, and our pharmacy services is the totals across the continuum of care, from our acute pharmacies, our acute care pharmacies within our hospital. We have retail pharmacies, we have specialty, long-term. It's money well spent. We'll spend an additional $1 million on the 800 compliant rules going into effect in 1/1/2015. We are overwhelmingly supportive of that and adhere to these guidelines to prevent patient harm, including death, that could result from contamination due to poor and inadequate standard operating procedures in our compounding IV rooms. USP 797, you all know, addresses proper hand hygiene, garbing practices, aseptic technique, surface contamination, appropriate sampling plan, etc. These are necessary QA processes, but intense documentation as it stands today. We also address within 797 the competency of our IV technicians and our pharmacists. So 7, the lot number and expiration date and manufacturer, to me, is non-value work that I'm having a difficult time understanding how that provides value for patient safety. Don't forget, we're already documenting, as we make the product, that expiration date, who made it and who checked it. So my concern is if now we have another log to document for the ingredients, lot numbers, and expiration date, if we're not too careful, we're going to over-document and we're not going to pay any attention to the integrity of the product, and it might compromise the product. Certainly, a lot of us have central IV batching centers that we ship to all our hospitals. Certainly, I support the lot and expiration. I think we all do, and we're coming up here from Charlotte today. In many cases, when you're making an IV, you're using multiple vials sometimes, or multiple amps that could be from multiple manufacturers with multiple lot numbers. Then you have the diluent. And so if you're on any given IV or compounded product, we could be diluting or through the computer or through a software, and so there's another possible source of contamination. I think there could be a possible delay, especially on the emergent compounded items. It's very labor intensive. This rule would apply at 40-odd hospitals. We're making tens of thousands of these products a day. So this is going to be particularly labor intensive, but that's not the purpose. I believe I don't mind spending extra labor if it provides value, but I am challenged in terms of the value part. And then lastly, no matter what our scope of services are within the hospital pharmacy, there's still product that's made outside the four walls of the pharmacy. So I think we'll have a double standard where the product made perhaps in the cath lab is not going to be subject to these rules. And so there's two standards of care. I thank you for listening, and I appreciate your time.
Thank you, Mr. Carter.
Can I ask a clarifying question? And I did, Bob, I did emphasize to everyone that the purpose of comments is to perceive them, not to debate the folks. So I'm just asking a clarifying question to make sure that you can be, as the board contemplates a rule that can correctly respond. I want to be clear. Are you speaking, and assume that I'm the dumbest person you've ever talked to, which is probably a safe assumption. Are your comments, and maybe there may not be a yes/no answer to this, it may be any or all of the above. I just want to clarify, are you speaking to paragraph I in the proposed rule?
I believe so, if anybody has them.
Because, and I ask that because I know that there are labeling requirements. Everybody's shaking
It
yes,
is
so I
odd.
think we're all on the
Thank
same.
you.
So you're not saying that the rules should adopt something less than what 797 and 795 require. You're asking whether paragraph I, which if that requires something more than USP 797 and 795, does that need to be in there? Is that? I just want to make, is that accurate?
Absolutely.
Okay.
797, we're not obligated to document lot in that. So yes, it would be paragraph I.
And again, I'm not the USB expert. I'm arguably not the expert on anything, but
No, I appreciate
but
that.
but whatever 797 would require in terms of documentation and the like, I shouldn't say that. You're not saying that there should be something different from 797. Just
No.
okay.
No.
I'm
797 was well needed. We all support it. We're dotting every I and crossing every T, but I think this extra requirement in paragraph I is just something that I'm having a hard time understanding the value to our patients.
USP standards require a formulation record and a compounding record, and that's where that information would be.
All right.
It's expected to be documented now. It's not our purpose to get into a big debate here, but if you're a patient laying in the bed and you've got a TPN hanging that's got 20 ingredients, wouldn't you like to know that somebody's keeping track of the individual ingredients in that?
On TPNs, we are. High-risk drugs, we are. We're keeping logs for expiration on, I'm speaking for myself and Carolina's, on all the chemo products, blood products, and TPNs.
So you're tracking lot number and expiration date for every ingredient?
Absolutely.
How are you doing that?
We're doing it right now manually. We're looking at software. We're doing some simplified 797 software. We're looking at some other software.
Thank you, Bob.
Thank you.
Good to see you.
Thank you, Bob.
Chris Beringers can come up, and he's going to share photos from our days of living at the Capasai House.
I'm not against blackmail either. As Jay said, my name is Chris Beringer. I'm a pharmacist for 21 years now. Jay and I went to Carolina together, lived at Capasai right down the road. We won't talk about those times.
Not on the
Do
phone.
you assume any responsibility for him?
No, absolutely not.
See that straight up?
He did live right in
Sure,
front of. We lived on
disclaimer.
the same hall, like right
There's
across.
a
from each other.
disclaimer there. Okay, I'm good.
And you're with which facility? I'm sorry.
at Carolinas Medical Center
Okay.
Northeast in Concord, North Carolina. I've been a pharmacist for 21 years now. I worked 7 years in retail. I've been in 14 years in hospital now. When USP 797 came out, I actually went to Washington, D.C., and when they were arguing the rules and the regs, so I've been involved with USP 797 since the onset. I've either been a pharmacy supervisor over the IV room or the pharmacy manager in charge of the IV room for the last since 797 came out. My hospital in general, so 450-bed hospital, is very pharmacy friendly. I can thank you guys for that. You've really set us up to be more involved. We have pharmacists in the ER, pharmacists in the OR, pharmacists on the floors, pharmacists doing rounds. We've got pharmacists in the clinics. I've got validating techs. All my techs are certified. We have a very awesome hospital. With the onset of the Affordable Care Act now, productivity has been scrutinized immensely. We've reduced our staffing 12% in the last year alone, just so we don't go out of business. The value of the pharmacist is to be on the unit and be at the patient's bedside. I'd like to get more involved in patient discharge, which is going to take more pharmacist productivity to get to those areas. Our IV room, we're 797 compliant. The Board of Pharmacy just did our inspection there. They found 0 discrepancies, except for the question of low-risk compounding. Should you be documenting that or not? That was a question that we're kind of arguing here. I average about 700 mixes a day during the summertime. In the wintertime, we have over 1,000 items coming out of the IV room every single day. We have one technician and one pharmacist in there 24/7. Some of our items are pre-mixed. We do batch several items, and if this batch is medium risk, so it is documented with the lot and expiration date per 797. What we have an issue with, if it's a low-risk, single patient mix, that all we're doing is mixing per the package insert. We're reading the package insert. The package insert says dilute with this and increase, and then dilute with the diluent, and then add to a total volume of 100 to a bag. USP 797 does not require that to be documented. They require documentation for medium risk or high risk. So
Are you sure about that?
yeah, pretty sure. I'd have to. I've read 797 pretty intensely. It's not a requirement for low risk compoundings to be documented. Because it's no different than reading the package insert with amoxicillin. You read the package insert, it says put 100 mLs of sterile water and shake it up and give it to the patient. Like for instance, if you're doing ampicillin, dilute with normal saline, add to a 100 ml bag. document the lot expiration of every one of these, then assign it another lot number, you're talking 30 seconds to a minute.
So you're arguing that reconstituting a vial of ANSF is not compounding? That that's simple reconstitution?
Simple reconstitution.
No, it's not true.
It's no different than, it's readying the product for delivery. It's per the manufacturer, readying the product to be dispensed. Just like amoxicillin suspension. But if I have to send I would require a second technician just to document that 400 or 500 items a day that's going to be used within an hour. If that's a recall 6 months down the line, I mean, I've worked in those small hospitals who say they're compliant with this. All they're doing is they're printing a label, putting it on another piece of paper, throwing that piece of paper into a box, and shoving it in the corner and never be seen again. For patient safety, my pharmacists need to be on the floor. When I take another technician out of the front, that's just going to leave more things for my pharmacist to have to check and verify as well. Where I could be having a validating tech doing the dispensing and verifying some of the dispensing items, and have my pharmacist actually on the patient's floor talking to patients about medications.
Any other
Chris,
comments?
can clarifying question. Chris, I'm taking notes, and unfortunately, my brain doesn't for 2/3 the speed it used to. I think I'm right. Your comment is substantially similar to Bob's.
It's
Is that
very,
you're
everybody
A-OK?
here, this is going to be their comment.
Right, you're A-OK with
With
whatever 797 requires, and again, with the disclaimer, I'm no 797 expert, so I can't speak to that intelligently to the extent I can speak to anything intelligently. But if 797 requires it, you guys are okay with that. The concern would be if the rule, either on its face or in its operation, was requiring something more than USP standard. Okay.
Right.
I just want to make sure I've captured it right, that's all. All right.
Anything else?
That's it.
Any comments
I
from the
got
board?
one. So you're still going to have a pharmacist checking the
Absolutely.
final product, no matter what?
Absolutely. There will never be a tech checking compounded prescriptions, never.
Thank you, Chris.
Chris,
Sound-
thank you, brother. Good to see you.
Sounds to me like you're arguing for a lower standard for hospitals than you would for a community pharmacy who does sterile compounding.
Well, the community pharmacies, they're dispensing it for somebody that's either going to be shipped miles away. I'm mixing something that's going to be done immediately, and if the nurse on the floor does it, they don't have to do that. And they're mixing it probably just as soon as the patient that I'm mixing it for. I'm not looking for lower standards, I'm looking for the same standards with USP 797.
Thanks, Chris. Raul Daniels. Just so everybody knows, if you look behind, Raul sent in a letter. Do appreciate that, Raul. That you guys have behind your tab, which you're free to refer to. And obviously, Raul, you're not limited to talking about that letter. Anything you want to talk
That's
about.
all that I will speak to, actually. Thank you for the opportunity to come talk today. I'm Raul Daniels, Director of Pharmacy at UNC Hospitals in Chapel Hill. We are, as you probably know, around an 800-bed academic medical center. Similar to my colleagues that have presented, we have a mix of facilities, a full range of pharmacies that we offer different products through, and sterile products in particular. We did submit some language, a friendly amendment to Section 2801, paragraph I, lines 8, 9, and 10. We really feel that the intent of the board is to be able to identify what products were prepared for which patient, by which pharmacist, and on what date. And most labels already do include all of that information, and most information systems are able to readily retrieve that information should there be a need to look that up. So we are, similar to Bob's comments, we're asking if you would consider in a friendly way to make the lot number an either-or option. If the labels already include the patient name, date, drug, pharmacist, all the data that is really needed to look up that information, a lot number may really become irrelevant at that point. especially with information systems. So the phraseology that we've recommended is to strike from line 8 the phrase "a lot number sufficient to identify," and really move that to the end of the sentence in line 10. So the reworded amendment would be: the labeling of all compounded drug preparations shall bear the preparation, the date the preparation was prepared, the identity of the pharmacist responsible for compounding the preparation, or a lot number sufficient to identify this information. And so we feel that it still contains all the information necessary, just giving the hospitals an option to use lot number or all the detailed information.
Any comment?
Any comments or questions?
Questions?
Yeah. How's that going to answer the question of a complex TPN?
I think on the more complex hazardous drugs, complicated items like that, there has to be a higher standard associated with that.
And Ralph, is it
it
your
is-
understanding that 797 has that in it for the
Right.
higher, okay.
And again, this proposed language does not lessen any wording in 797.
Yeah, that's the only thing, I just wanted a clarification on that is, you're looking at paragraph I and saying, paragraph I of this proposed rule says, in that specific thing, says what the board wants to have is identity of the preparation, the date it was prepared, and the pharmacist who prepared it. And your position is that a lot number could be assigned to capture that information, but if your existing label or record or whatever already has that in there,
Right.
is that enough? So, I mean, like and again, so for example, would your position be like if there's an order number, could the order number sort of be the lot number? And maybe I'm junking this up and I shouldn't do this, but.
Not necessarily that. I think for a lot of these immediate use products, we're going to maintain the level of sterility necessary. We're going to maintain all the appropriate documentation. The addition of a lot number in those circumstances doesn't necessarily add any value when we can, if there's a question about an individual drug, we can do a query in our system and look it up and know what was prepared for what patient on what day. And so just questioning the necessary, the
Did I hear
need
you
of
say
a lot number.
immediate administration,
Yes, sir.
as in mixed at the bedside?
I'm not mentioning nursing or procedural areas, those types of things. It's just prepared by
I
pharmacy.
believe would be covered under administration, but I still say that what you're arguing for is a lower standard for hospitals than is required of other sterile compounders. And the argument is because of the volume that you do, and that's not convincing.
I can't speak to other providers.
Anything else? Thank you all very much.
Well, I sure do appreciate it, and I
Thank
do
you.
appreciate you sending in. It's not often at Clinton I have the luxury of somebody sending in proposed writing, so thank you very much for that. Deanne Brooks is here from Cone. Come on up, Deanne.
Thank you. Good morning. My name is Deanne Brooks, and I'm the Executive Director of Pharmacy Services for Cone Health. We represent about 1,000 inpatient hospital beds within the Guilford County, Alamance County, and Rockingham County regions. We also have some outpatient pharmacies as well and clinics. I would like to speak to you also in support of my colleagues from Carolinas Health System and UNC in specifically to the Section I of the proposed ruling. And I would like to make a little bit of clarification between the difference between the compounding pharmacies and what we are asking right now in terms of not including lot numbers for low-risk IV preparations. And when we do prepare within the hospitals batches of medications that we may prepare that are then given a little bit longer expiration date, again, subject to USP 797 regulations. And we do record all of the lot numbers and expiration date for those batch preparations, and that is very similar to what a compounding pharmacy would do as well. Not all of our hospitals have the technology to be able to very easily determine all of the patients who would have received a particular lot number of a medication. We can very easily identify who has received a medication and when they received that medication. But the actual lot number is a little bit more difficult, is a lot more difficult actually, without the technology. So for a hospital that doesn't have that technology, potentially there could be, as Chris mentioned, there's a label that's put on a sheet of paper and thrown into a box, and there are tens of thousands of those per month. So if there were a recall that we wanted to identify those patients that received that particular lot number of medication, it would require us to go through those tens of thousands of pieces of paper or pieces of labeling, and we would be able to identify some of the patients who received that particular lot number, but we would not be able to identify with 100% surety all of the patients who received that. And we have mechanisms that if there were a recall after these patients have received these medications acutely, that we would notify those patients and we would let them know that they may have received this medication, and we would let them know what they need to be on the lookout for and to notify their physician. So we do have mechanisms for that. Because if we were to look at all of those hand labels with handwritten lot numbers, it would be so easy. We all know how long the lot number is. To just miss one letter or one number from that lot number, we wouldn't be able to 100% assure that we were contacting all of the patients who received the medication.
Dan, just quick, so just, and I know I'm repeating, so again, your position on behalf of Cone Health is that if 797 requires it, you're good with doing it.
Yes, sir.
If 797 doesn't require it, you're asking specifically about if in your view that's a supra 797 requirement, you would ask that not be in the rule.
Correct.
Okay.
Yes.
I think you just made the perfect argument for why we need to be able to track lot numbers or expiration dates.
Okay. Thank you.
Thanks, Deanne.
Thank you, Deanna.
Thank you.
Catherine Brown's here from Novant. Come on up, Catherine.
Hi, I'm Catherine Brown. I'm a pharmacy director with Novant Health. We represent, I think the count is 15 acute care facilities in North Carolina, South Carolina, and Virginia right now, primarily in North Carolina. I really would like to, I guess, clarify the issue around the worst case scenario. So, considering a family member of mine received a medication which was later found to be contaminated. I have a friend who actually had this happen with the New England compounding situation. And I have no doubt that everyone in this room and everyone that works in our profession is committed to ensuring that we establish the truth about safety around those products. My colleagues have stated accurately, and I support their comments around our current system limitations to a clean answer to that question. So really, I mean, transparently, the default situation is treating all patients in a time frame determined by the manufacturer to be relevant to that recall as if they received a contaminated medication. Similarly to what we would do for an intramuscular injection, an oral product, a suspension that's been reconstituted improperly. The default situation is assume that you did not get what we intended you to get and treat it accordingly, which isn't a clean solution, but it's not a turning of our backs to our responsibility to those patients either. I agree with the concept that our health systems in North Carolina support the USP guidelines, which I have a copy of in front of me, and they state the labels of compounded sterile products bear correct names and amounts or concentrations of ingredients, the total volume, the beyond use date, the appropriate route of administration, the storage conditions, and other information for safe use. There are correct identities, purities, and amounts of ingredients by comparing the original written order to the compounding record, that correct fill volumes in compounded sterile products and correct quantities of filled units were obtained when the strength of finished compounded sterile products cannot be confirmed to be accurate based on the above 3 inspections. So they go on a little bit further. There is not language specific to lot number in that. I agree wholeheartedly with Dr. Daniels' amendment to Section I. Again, back to the value proposition. So how do we create a system that's valuable for our patients, and certainly tracking for batch compounded items. So a batch means it's going to sit, and we need to be able to recall it off the shelf if we find that any minuscule item that was used to create that product has a problem with it. And for those, all of our hospitals are in compliance and complete agreement with. Where the value proposition starts to fall apart a little bit for us is to say an immediately used or just-in-time prepared IV can't be pulled from a shelf because it's already been consumed. So at that point, the value goes back to that identification of patients who receive that medication. And it's true that our current systems are limited outside an extremely manual system to achieve that. But again, our default is to use the information that is readily available, which is all patients who receive all drugs in all time frames, and to treat that accordingly. Thank you for the opportunity to comment.
Clarifying question. I'm not going to ask the same clarifying question I've asked everybody else. I think that even I have
Promise?
it. Even I have it by now. Make sure my notes are correct. Batch versus individual. It's individual plus immediate use, right? Is that sort of what you're talking, that your position 797 doesn't, in your opinion, and tell me that's not my opinion and go to hell, you don't know what you're talking about, that's fine. But individual immediate use preparation, that under your understanding is under USP 797, that would not require some of the same labeling requirements that this rule does. Is that
Correct.
roughly correct?
It requires the components listed in paragraph I, accepting the lot number, which, as Dr. Daniels pointed out, could be used as a way to point to that other information, but as an additional requirement creates a burden of manual record keeping.
Okay. That's very, thanks again. I'm not arguing any of that. I'm just
Well, it is,
trying to get
it's
it to
confusing
penetrate
because we use, especially in the hospital setting, we use the term batch
Right. Okay.
in an operational sense to overlap in some of those different products. So I think it has been confusing. Legitimate.
Thanks.
Thanks, Catherine.
And I know Jonathan Pritchett's here from Central Compounding. Hey, there
In
he
the
is.
overflow chair.
Yeah, that's right.
And I guess
Usually
some
that's
hot-
a defendant's chair, Jonathan, so that's
Here we go.
that's a
Yeah, so I've got a couple of things I want to talk about. First, my name's John Pritchett. I'm pharmacy manager with Central Compounding Center here in Durham. We do sterile as well as non-sterile compounding for human and vet use, so we see a little bit of a different perspective of things than some of the folks that have talked about this morning. First thing I want to talk about is the section I with the labeling, but I'm going to hit it from a different perspective. On line 9 in that section, it states that the label must contain the identity of the pharmacist responsible for compounding the preparation. In our practice, the there's really 3 stages where a pharmacist could be involved, and that's going to be data entry, compounding, and then the final check of the preparation. And truthfully, we usually have technicians that are doing the actual compounding. So we'd like to clarify who is really the dispensing pharmacist in this situation. Right now, if we run a label through, very similar to any traditional retail pharmacy, we'll put that label through, and whoever pharmacist in charge that's logged into the system, their name is going to come up on that label. They may never actually be involved with putting the compound together, and when that compound's complete, what we do is we have a formulation record that a pharmacist is going to check off in the end. I would think that person at the end really qualifies more as the dispensing pharmacist in this case, but the label's already printed. So it creates a, I don't know if we need to talk to our compounding software manufacturer and see if they need to add a blank where we add an additional name, or if that pharmacist in charge's name is sufficient. And we can always go back to the master formulation record. So the label will have a lot assigned to it, where we can always go back and trace back who made the compound, all the ingredients, and which pharmacist signed off on it. So I guess just further clarification on whose name that needs to be on the label is what we'd like to see there. Any questions about that before I jump to the next section, or
John, can I just ask a
clarification?
clarifying question?
Yeah.
To your knowledge, do USP standards make that definition or make that? Okay.
No, not to
Jonathan,
my knowledge.
repeat again, I'm sorry, what you want.
So
Considered-
the rule says that the dispensing pharmacist's name
Yeah.
should be on the final product. And I'm looking at it from the perspective, like at our traditional retail pharmacy, if I fill a penicillin prescription, if I'm logged in as pharmacist in charge, and maybe I did the data entry, maybe a technician did it, but that prescription's put in the computer, the label's printed out at that point, then pills are put into the bottle, and the pharmacist checks it at the end. That pharmacist's name isn't necessarily the one that's on the label.
Exactly.
And it's really further complicated in compounding because there's just, there's extra steps in the process. So whose name does that need to be on there?
What would you propose the language say?
I would love it to be the data entry pharmacist. And now in our particular practice, and we'll get into this a little bit in the next section, but we label our patient-specific things with using the compounder software. Any office use products are labeled by a separate label that we create, and that one we could put the dispensing. Yeah,
Careful, you read DQSA, haven't you?
I have.
I just want to state for the record,
Yeah, that's the next can of worms.
federal law says what it says on that. Jonathan, let me back I was trying to take notes and run my mouth at the same time, which is a problem for me and to your. So, just to read, so the line says, in the identity of the pharmacist responsible for compounding the preparation, and I'm just trying to recapitulate.
Well,
my notes.
and I would say a pharmacist may not even be the compounder. I mean, are we talking about the person physically mixing with a mortar and pestle, or are we just talking about the person who ultimately signs off and gives approval to that product?
Okay.
I would think the dispensing pharmacist would be the correct
I would too.
final check person.
Yeah. So
Okay, that's what I was I'm sorry, that's where I jumped the rails, I think, is that I in my notes I had, you had said, you were asking for a clarification that the pharmacist responsible for compounding would be the pharmacist who conducts the final check of the compounded product and dispenses it to the patient.
yeah.
Is that right? Okay. For some reason, I wrote down later on that you then came back and said you thought they should be the data entry pharmacist, and clearly I had a
In a
minor
tradition,
stroke.
in more of a traditional setting, that is what you get.
Okay.
So we're I guess adding an extra step because it's a compound. I want to make sure we're understanding that right.
Okay. I'm sorry for interrupting, John.
No, that's fine.
I want to make sure my notes.
I don't
were
know
right.
if at all, you want it to make sense, so. All right, and the next one, going kind of towards the DQSA stuff, just want to state my piece about it, I guess. So in section 2800, page 1, lines 14 to 16, it addresses office use compounding and states that compliance must be maintained with applicable federal law. Right now, under section 503A of the FD&C Act, it's stated that the drug product is compounded for an identified individual patient based on the receipt of a valid prescription order. I and a lot of my compounding colleagues I've talked with, we just feel like this is a big hurdle to patient access to medication. It's going to drive up costs. It's going to be very taxing time-wise, like we've talked about a bit this morning. And I don't think that it really addresses the safety of the product. 2 examples of things we make right now, there's a cataract gel. It's a topical preparation that surgeons use when they're removing cataracts. Right now, we have surgery centers that order it directly from us, and they'll call and say, we've got 30 cases this week, and we'll send over that many doses prepared, ready to go for them. We don't know who those patients are at this time. And that's obviously going to be changing. But when we send it over, it has the name of the drug, it has the ingredients, a lot number, and expiration date, pharmacy information, any pertinent data that's needed. We don't always know who the recipient is on the other end, and this works efficiently because surgery centers, they don't always know till last minute who's going to get what. People get scheduled, they're added, they're dropped. So this allows some flexibility with the center. If Jim Smith cancels, Jane Doe can come in and have her surgery done. And then logistically, scripting out each order is going to be a complete nightmare. It's going to increase a lot of time in the healthcare system. It's going to increase drug costs. We're going to have to fill every one of the single doses as a new prescription. So that means the patient's going to have to meet with the surgeon. They're going to have to get a prescription. They're going to have to bring it in. We're going to have to fill it. And it's just going to create a lot more time and cost involved there. And with sterile products, we're probably going to have to do some tamper-resistant packaging because I trust a healthcare facility to maintain the kind of chain of custody of the product and make sure it's done right a lot better than me giving it to a patient who takes it home and their dog licks it or they leave it in the car or something like that. Another one we do that's a non-sterile product is a dental anesthetic gel. So this is something where a dentist has little gel at the ready, and I'm sure you've probably been in the dentist chair before and they tell you it's time to drill. Well, with this, they could pull it out, go ahead and numb the gum up, do the injection, problem solved. If we couldn't do this sort of compounding, it's going to be a situation where either you do the injection with no anesthetic, or it's going to be, okay, we'll reschedule you for another day, go to the pharmacy, get this prescription filled, jump through all those hoops, come back, and it just, again, wastes a lot of time and money. I don't think that really helps safety any. So my proposal, something to consider, and the whole thing with the DQSA, it seems to be a very fluid situation right now, and I feel like we're hearing new things all the time. Some states have started using a roster system where they'll get a retroactive list of which patients received the medication, and then could attach that. So if I have a formulation record with a lot number and could receive back from the practitioners who got what, and we could attach that to our records and keep it, then we would have on file who those patients were. And then also getting away from that stuff right now, with 503A, it only addresses human medication, and I don't know if in the board's compounding modifications here, they might want to address veterinary practice. Sorry, Bill. Quit talking. I'm done.
Sorry.
John, let me ask a couple of clarifying questions.
Yeah.
It's certainly clear from your comments you have no love for the Drug Quality and Security Act. I guess my question is, what is it you're suggesting? Is you're suggesting that the Board of Pharmacy should sort of say, we don't care what federal law is, go forward?
From what I understand, there's been several states that have gone and made their own rules about that. And I'm sorry, I wish Jennifer was with me here today. She's on the IACP board, so she's a bit more in the weeds with what's going on with that. But some states have decided to take laws where they do the retroactive list or something
And
like that.
just for the record, so I can state it, I was at a meeting about this. FDA has stated clearly that a retroactive list does not satisfy Section 503A. I'm not saying whether, I hear you, I'm not making an argument about whether, because I've been beaten about the head and neck for sort of saying, here's what the law says.
Right,
I'm
right.
not saying whether it's right or wrong, but FDA has already said, I mean, would it be is it your suggestion that the board pass a rule that violated federal law? And if so, do you have concerns about what the consequences to you and others would be as a result of our doing that?
Can we talk about that later?
I'm just, no, you don't have to say anything. I'm just asking. I mean,
I think that the issues with how the FDA is doing things they're a big hurdle to patient care. And
let's say everybody had policy preferences on that. I guess my question is it your suggestion that we write rules that sort of try to overthrow federal law, or are you just making a statement that pharmacists need to talk to the federal authorities and see if they
that would probably, I mean, I would love to see it if we could take that fight on. I don't know if we really if you want that.
I'm just going to say, as legal counsel for the board, that I do not suggest that this board get into the business of writing law that flatly contradicts federal law. And my opinion, and I guess this will be my public comment, my opinion is that invites consequences to this board as an institution and to pharmacies in this state that would be potentially devastating. So I will point out that, just for clarification purposes, that the reason the rule is written as it is about such a compounding pharmacy shall comply with applicable law is I can report, and Bill can tell me, say if I'm misstating what the intention was, but the intention was that if there are changes in federal law, that we don't have to go back and redo this rule every time this happened. That if Congress amended the DQSA to allow some off-use compounding, you could do it. Or if the FDA issued regulatory guidance or new rules that allowed it in certain, you could do it. We're not, these rules aren't, as drafted, they're not designed to create an additional hurdle. They are to say, look, if it's allowed, if doing it fits within federal law, then there's no state barrier to your doing it. But if it violates federal law, and I do just want to point out that the Drug Quality and Security Act does place a specific obligation on state boards of pharmacy to report to the FDA when they have a pharmacy that is not complying with Section 503A. And so just to keep in mind that if we were to write rules that said you can do all of these things under state law no matter what federal law says, I would ask that it be considered the position that it puts staff in, that we would then be obligated to report to the FDA every pharmacy potentially in this state is violating federal law, and then the feds could decide what to do with it. So that's just, given the background, again, I want to be clear, I'm not saying whether Congress was right or wrong in the balance they drew. I'm just saying that's the lay of the land with federal law. And I know that there are lots of people working to change federal law, and if they are successful with that, there's not a thing in our rule that would require us to come back and redo all of it.
And that's exactly why we wrote it the way we wrote it. Do we like it? No. I mean, do I like it? No. I mean,
Can I speak to clarification on veterinary compounding? John is right. Section 503A does not say anything about veterinary compounding, and veterinary compounding at the federal level, my understanding, is still governed, if that's the right word, by a compliance policy guide that FDA issued, in 1984 or something like that. So there's nothing in our rules as written that would require, that deals with that. That's a whole other bill. That's a whole other ball of wax out there, but you are correct that 503A speaks only to human compounding. In fact, I can report that the FDA has confirmed that and said it doesn't have anything to say about veterinary compounding. And they refer back to their compliance policy guide. So that's that. And the other thing, just for the record, is that DQSA also has a specific exemption for radiopharmaceutical compounding too. So that has nothing to do with our rule, but just a background of what the DQSA has in it.
May I say something? Those of you here from the hospital systems, I'm very sympathetic to your issues with documentation, but I'm gonna tell you, we live with this documentation stuff every day in the community compounding setting. The other thing I want to say is, the USP expert committee that labors over USP Chapter 797 and other chapters, like the proposed Chapter 800, you can apply for membership to those committees. As a matter of fact, right now is the time to do it. If you want to influence those standards, put your name in to be on the committee. And make sure, when the proposed chapters do come out for comment, that you go through them and do submit comments. Thank
Mr.
you.
President, that's the last person who signed up, and I did want to make sure, John, thank you very, very much. If there are others who do wish to speak, who've been moved to speak, they have an opportunity to do that. Clint's going to go check in the overflow room on that. I would like to express my thanks as a staff member to Bob, Chris, Raul, Deanne, Catherine, and Don. Oh, yeah, yeah, come on up, and here, let me get you on the record here.
Thank you. I'm Gabby Houston, representing Novant Health this morning, and also a member of USP Expert Compounding Committee, although my opinions today don't reflect that.
You're here in a personal capacity.
I'm here for Novant, yes. And I would just like to state that I am in agreement with what the other health systems have proposed in regard to paragraph I, in that it creates undue burden in trying to manually track a lot number that, in my opinion, would not enhance patient safety, and that the product would already be administered by the time we would receive a recall. And pretty much we're doing just-in-time preparation of medication, so the medication's administered within hours of when it's prepared. So I don't feel like that really adds anything to safety. And we certainly are tracking lot numbers for batches or lots. I mean, by definition, I would think a lot is multiple individual units that are of the same ingredient. So really, an individually patient-prepared preparation is not really a lot per se. It's an individual preparation. To my knowledge, Chapter 797 does not address putting a lot number on the label. And so that's, I would suggest that's just creating undue burden and having to manually add that. Currently, computer system technology does not allow us to do that. And I mean, it would be great if manufacturers barcoding would encompass or capture the lot number and expiration date. And we are barcoding, but currently that's not the state of technology. Thank you.
I just want to confirm what you said. I just scanned the chapter and I can't find anything that specifically says that it's required.
Correct. Yeah. Thank you.
Debbie, thank you very much, and just so your, no, I got it. You didn't say anything different than others. I'm trying to keep up with that. Thank you, Debbie.
Thank you.
I think we have more USB expert committee members in North Carolina than any other state, which is good, than any other state in the union. Gigi Davidson is on the USB expert committee as well. She has been working with the Pharmacy Compounding Work Group. She had wanted to be here today but could not. But I did want to acknowledge that she also, as a member of the USB expert committee, has been involved in developing this. So Debbie, thank you.
Thank you.
Did you just get back from USB? Didn't you guys just have a meeting?
We had a
Or-
meeting last week.
Yeah, okay, that's what I thought.
Mr. Campbell, do we have any other members for public comment?
Anybody from the, no, I think,
Oh, we got one in back.
Danny,
It's
you
a
want?
general question.
Yeah, you come on up. Okay. Danny, I'm gonna put you on the roster here, and I'm writing you down as David Work.
Good morning, I'm Danny Barnes with Triangle Compounding Pharmacy, and we are 503A and also FDA registered 503B pharmacy. I'm the president and owner. My question is really more of a procedural question, actually, is the timeline and the wording and kind of the process going forward in the timeline was really my question there. We obviously support compounding for as being a 503B registered compounding pharmacy, human drug outsourcing facility. All of the quality measures that are taken, we're also PCAB accredited. So we obviously support anything that goes back to patient safety, whatever that may be. And we do not consider cost, necessarily as a limiting factor or to come into that decision. Obviously, we all have budgets and things we have to do, but we're for whatever measures protects patient safety first and foremost. But that was really my question.
What I was gonna suggest on that, Danny, is if, that those very questions about procedure going forward and timeline, that will be subject to, once the public hearing closes, we'll have exactly that discussion with them. So that's gonna come up, and if at that point, you haven't got one.
Second motion.
All in favor?
Aye.
Motion carries.
I also have a couple of comments, if you would
Yes, sir.
bear with me. We've received a lot of information today, and I understand that there's a lot of thought going into these comments. As a board member, I need to have more time now to digest the information we've received today and to apply that to my limited knowledge of what we're talking about today, that we can make a better decision. So based on that, I think that a decision today would not be a wise decision, or it might be a wise decision, but it might be a hasty decision.
Okay.
So I would suggest that we take this under advisement, that we schedule a future meeting to actually act on this, the rule as presented at the present time, that the public be notified when we're gonna vote on that, and that during the time frame between that now and then, as you spoke about, that we devote ourselves to understanding the input we've received today. And having said that, I'll ask the board to agree with that or not agree with that. Then I have one more comment.
Okay. Mr. Campbell?
I agree.
Appropriate, Clint, did I leave anything out on that? So those are your options, comments. Jimmy Jackson sent in a written comment, and his comment was compounding issue. step back, would ask that the board consider the minutes of the July 2014 monthly meeting and the August 19, 2014 board conference call meeting.
Okay, we have the notes behind that. Do I have a motion from the staff, our board to approve those minutes?
So moved.
Do I have a second?
Second motion.
Okay, all in favor?
Aye.
Aye. Motion carries. Mr. Campbell?
Mr. President, next time on the agenda, we have a petition for reinstatement of license from Matthew Rosinski, who's sitting right there, and Belinda is here with me, so y'all come on up. So the board is aware, as is my custom in petitions for reinstatement, I did meet with Matt and with Belinda about 3 weeks ago to discuss this. Matt, just to remind you, so the procedure today will be I'll give a brief introduction to the case to the board members. At the conclusion of that, I will have some questions for you. And then the board members may have questions for you after that. Then I will have a few questions for Belinda, and the board members may have. And then at the conclusion of my asking questions, if there's anything that you have not been able to say that you want to say, or anything you want to present that you haven't been able to, you will certainly have your opportunity to do that. And then we'll summarize the matter, and then the board members will debate it. So I guess to get started, Cindy, we'll go ahead and swear the witnesses, and we will start immediately afterward.
I do.
Thank you, members of the board. Brief background on this case. Mr. Rosinski, I'm sorry, Matt, or you're probably Dr. Rosinski, aren't you?
No.
Oh, you're a BS just like me? All right, well, we can BS together. Mr. Rosinski surrendered his license to practice pharmacy in June of 2013 after it was reported to the board that Mr. Rosinski had appeared for work at Alamance Regional Medical Center impaired by alcohol. Since that time, Mr. Rosinski has undergone evaluation and treatment, which we will discuss during the questions, and is a PRN client, and is here seeking reinstatement of his license to practice pharmacy with appropriate conditions. Obviously, Belinda is here with Matt, and PRN does advocate for Mr. Rosinski's reinstatement with appropriate conditions. So with that then, Matt, I will go ahead and ask you, if you would, please identify yourself for the record.
Matthew Rosinski.
And Mr. Rosinski, is it correct that you surrendered your license to practice pharmacy on June 28th of 2013?
Yes.
And if you would, please describe for the board the circumstances that led to that surrender.
On June 21st, I went to work in the morning, and I clearly shouldn't have. After a week of paid suspension, administrative leave at work, blood results confirmed that I was impaired. Then I was terminated or resigned from my job and called, I forget the investigator's name, but called the board to surrender my license, and then contacted Cindy Clark at NCPRN.
Pat, if I could just back up and backfill a little bit. So it was on or about June 21st of 2013 that you reported to work at Alamance Regional Medical Center. Is that correct?
Yes, sir.
And what was the nature of your position at Alamance Regional Medical Center?
Staff pharmacist.
And
Cancer Center.
I'm sorry. Go ahead.
Staff pharmacist at the Cancer Center.
Okay. And when you reported to work that morning, is it correct that other employees were concerned about your condition that morning?
Yes.
And you were confronted is it correct that you were confronted that morning about your condition for work? Is that right?
That's correct.
And as a consequence of being, you were confronted by folks at Alamance Regional Medical Center, and they did they demand that you undergo a testing for possible impairment?
Yes.
And what was that test?
A urine screen and a blood test.
Okay, and as a result of the urine screen and the blood test, it confirmed that you had in fact presented for work on that morning impaired by alcohol. Is that correct?
That's correct.
And shortly after that, Alamance Regional Medical Center terminated your employment. Is that right?
Yes.
And we've already established that you surrendered your license on June 28th. After you contacted North Carolina Pharmacist Recovery Network, is it correct that you underwent an initial evaluation at the Pavilion Center?
Yes, sir.
And was that a 4-day evaluation?
Yes.
And what were the results of that evaluation?
They had determined I had a dependency upon alcohol, and they had recommended a 12-week course of treatment
Okay.
at an approved facility.
Right, and that's the recommendation, this was an recommendation of 12 weeks of inpatient treatment, is that correct?
Yes.
Okay. And did you in fact undergo inpatient treatment for alcohol dependence?
Yes, I did.
And where did you do that?
At CPE in Nashville, Tennessee.
Was that be correct, the CPE is the Center for Professional Excellence, is that correct?
Yes.
And you were there for 12 weeks, is that right?
Yes.
If you would describe in general terms the course of treatment at CPE.
We met Monday through Friday at the office that they had during the daytime. Group sessions, some individual therapy sessions with the staff members there. In the evenings, we would attend Alcoholics Anonymous meetings, and on the weekends. So every day we were attending Alcoholics Anonymous meetings in the community in Nashville. And during different nights, during the daytime at work, at CPE, just individual forms of therapy, group sessions that they did.
And approximately when did you, well, let me ask, did you complete the 12-week course of inpatient treatment at CPE?
Yes, I did.
And approximately when did you complete that treatment?
December 23rd.
And when you arrived, is it correct that you returned to North Carolina after that?
Yes.
And at some point after that, did you contact PRN again?
Yes.
And describe what that contact was and what it resulted in.
Well, there was on and off contact all along.
I understand. Let me restate. I don't want to leave the impression that you sort of stopped talking to PRN. I understand you went to inpatient. You had contacted them first. You went to treatment. But after you completed the 12-week course of treatment, is it correct that you contacted PRN again to sign a treatment and monitoring agreement?
Yes.
And approximately when did you do that?
December 30th.
So it's about a week after you returned. Is that right? And what's the duration of that treatment and monitoring contract with NCPRN?
5 years.
So you have been under specific contract with NCPRN for approximately 10 months at this point. Is that right?
Yes.
And in that 10 months, how would you describe your compliance with the requirements of that treatment and monitoring contract?
Compliant, very 100%.
Have you ever been assessed any points for noncompliance by PRN?
No.
You ever been sent to the compliance committee by PRN?
No.
Talk to the board, if you would, in these 10 months where you've been under contract with PRN, describe for the board in general terms what your recovery has been after inpatient treatment at the Center for Professional Excellence. What do you do?
It entails, well, I have a requirement to go to Alcoholics Anonymous meetings weekly, a certain number per week. I've been going pretty much daily. During that time, I've made contacts, different new friends that are in recovery in Alcoholics Anonymous sponsor. I also have to every day dial in or call in to NCPRN, or the lab that they use to see if I'm selected that day for a random urine screen, which happens. And going to meetings. Had been looking for employment sporadically. Primarily, I've just been trying to attend as many meetings as possible and just to follow the program NCPRN has outlined.
Matt, were you charged criminally as a result of the impairment at all?
No, not to my knowledge.
You have any charges of any sort pending against you
No,
at
sir.
this time? You described for the board that you were working at the Alamance Regional Medical Center in the Cancer Center there. Would you agree that, well, certainly the practice of pharmacy requires that you not be in an impaired state in all circumstances, but how would you describe the risk that had been presented to patients with your appearing at work impaired in June?
It was a very great risk to the patients. Anything could have gone wrong with that.
To your knowledge, well, let me back up. When you came in on June 21st, 2013, is it correct that you were confronted pretty quickly after you had arrived at work? Is that right?
Trying to think of the time. I mean, relatively. I mean, an hour or two after.
Okay. To your knowledge, was there ever any indication to Alamance or to you or to anyone of your aware that a patient had been harmed as a result of your appearing at work impaired that day?
No.
And I will stipulate for the record that we never received any complaint to that effect. Man, if you would talk to the board about what the root causes that you got at, that you have arrived at for the alcohol dependence, and how that has affected your daily life, and maybe specifically what your desires in terms of practicing pharmacy are going forward.
The root cause, I believe, probably many factors. Family history, just unhappiness, general unhappiness, isolating myself. The alcohol would tend to isolate me, and I would want to isolate for the alcohol. Just overall, I think it was just a general sense of unhappiness that was causing it. After treatment, just knowing that there's other things in life, in AA, there to do.
Recognizing the factors that contributed to the finding of alcohol dependence, if you were to go back into pharmacy practice, what kind of practice would you like to go back to, and how are you equipped now to deal with the factors that contributed to your dependence in practice?
I would still like to possibly get back into hospital work or home health care, if possible. How would I deal with that? I have a action plan, an intervention plan of action in place, developed with NCPRN to follow. I also have a sponsor in AA that I speak to pretty much daily, if not see in person. That may change once working. I'm seeing in person, I would still contact him. Develop a different group of friends in AA that have a different set of, I guess, goals and objectives for life. Seems much healthier. A support system with them, with NCPRN, my family.
I'm just making sure I've got everything. do not have any further questions for Mr. Rosinski. I do have a couple for Valanda, but board members, if you have questions for Mr. Rosinski.
Any questions from the board at this time? No. All right, Mr. Campbell.
Valanda, if you would identify yourself for the record.
Sure. Valanda Nelson. I'm the Executive Director of the North Carolina Pharmacist Recovery Network.
And in that capacity, Valanda, are you familiar with Mr. Rosinski's case and course of treatment?
Yes, I am.
And you've heard him describe the course of treatment that he went through or that he is undergoing. To confirm with you, is it correct that Mr. Rosinski has been fully compliant with this?
Yes, he has.
PRN conditions?
Yes, he has. He has not had any points.
And slightly aside comment, but it's common, is it not, for in the early going, a lot of PRN compliance have minor compliance problems. Is that correct?
Yes.
And Mr. Rosinski has not. Is there anything specific you'd attribute that to, or does this make, is he different in some way from?
I think he's very vigilant about, making a good impression and making sure there aren't any mistakes along the way.
In your clinical opinion, is Mr. Rosinski at a point in his recovery that he could safely resume the practice of pharmacy?
Yes, I agree.
Are there any recommendations that PRN would have about the conditions under which he would resume that practice?
Sure, we would have the usual restrictions of not being a pharmacy manager, not being a preceptor, and having an hours restriction.
When you say an hours restriction, are you contemplating, for example, a 30-hour per week limitation at first that can be increased at PRN's discretion?
That is correct. Mm-hmm.
Valanda, I'm sure I know what the answer is, but say I've asked this. 10 months of recovery, is that in your, and I recognize there's a period where he was in inpatient treatment, is that sufficient time in Mr. Rosinski's case to determine that the recovery is real and is proceeding as it should?
Yes, I believe so.
Is there anything, I appreciate Mr. Rosinski gave a good recitation of his treatment and monitoring progress at Pavilion and through CPE and post that. Is there anything that you feel like you should add for the board's consideration?
No, I think Mr. Rosinski is ready to return to work. He's been extremely compliant with us. He has a very strong recovery plan in place for returning to work. That's all I'd like to add.
I have no further questions for Ms. Nelson. Board members do.
Any questions from the board?
Or any questions?
Mr. Rosinski, do you feel like you're ready to come back to practice?
Yes, sir.
Do you feel like you can handle the stress that comes along with making that decision, going back to work, and incorporate that with your recovery plan and action plan?
I believe so, with the action plan and my support network.
Okay.
Yeah, yes.
And I did want to make sure if Mr. Rosinski had anything further he wanted to present or testify, certainly you have an opportunity. You're under no obligation, but you have an opportunity to do that.
No, sir.
Any other questions from the board?
Motion for closed session.
Second?
Second motion.
All right. We'll adjourn for a few minutes and come back and talk and tell you our verdict, okay?
Thank you.
back in.
So moved.
Second?
Second.
All right. All in favor?
Aye.
Yes. Ms. Riskins, we've reviewed your case, and the board has decided to agree to your reinstatement with conditions. You will stay in your contract as of December 30th, the 5-year PRN contract. You will advise the board of promptly writing any address change or work status once you get hired. You will not serve as pharmacy manager of any pharmacy. You will not precept any pharmacy students. We'll honor the PRN request at 30 hours to start with. Valanda, you can adjust that as you see fit, depending on his progress. That you'll comply with all terms of the order. Petitioner may be subject to additional disciplinary action by the board if you do not do that. Also, you'll violate no laws governing the practice of pharmacy and distribution of drugs. How are you on your CE for 2013 and this year?
I have, I think, about 5.
Okay, you just make sure you comply with your CE requirements.
Yes.
Our statutes.
To make sure it's understood, I will specify in the order that he will need to make an application to reinstate his pharmacy license, pay the appropriate fee, and show
Okay.
the appropriate CE.
Okay.
So I can take care of it in that way.
We congratulate you on your success and wish you the best and hope you move forward and take that seriously. You've got a second chance on your license. We expect you to follow that.
Thank you.
Okay?
Thank you all.
Matt, congratulations. Procedurally, I will draft an order, hopefully today, but certainly in the next couple of days. Get that signed, and I will get a copy to you, of course, and get a copy to Valanda as well, so NCPRN will have that. All right, best of luck. Congratulations, Steve.
Thank you.
Thanks, sir. Mr. Campbell?
Mr. President, next item on the agenda is a request to address the board concerning the dispensing of syringes from John Taub, and John is here. And I think I made it clear, John and I had a miscommunication. You know, he was on the agenda for a prior one. He actually had been here and left, but the communication problem was my problem, not John. So nothing to be drawn from that. I apologize, and John and I talked, and I apologize for that. And so you have a background sheet behind your agenda file of Mr. Taub's request. And Mr. Taub, I yield the floor to you.
That'll be fine.
First of all, I'd like to thank Jay and the honorable board here for allowing me to speak on a topic here which I think most people would shy away from. My name is John Taub. I'm a father, husband, business owner. I own a martial arts school and a medical device company here in North Carolina. I'm also a concerned citizen, and the purpose of me being here today is to discuss briefly the sale of syringes by North Carolina board certified pharmacists in the state. About a year ago, first of all, it's difficult for me because most people already perceive me as condoning illegal drug use, and that's clearly not the case. I'm totally against it. But there's an issue here. Whereas in the North Carolina legislature has already allowed the sale and possession of syringes without a prescription in the state. 3 things. First, whether you regulate or not regulate syringes in the state does nothing, absolutely nothing, to impact the use of illegal drugs. 2, by regulating syringes, you open the opportunity for the spread of noxious diseases throughout the state. HIV, Hep B, other nasty bugs. 3, it puts a great risk to our law enforcement officers. Now, I do not have to present to the board here today all kinds of data, literature. The North Carolina legislature has already done that. A legislature made up of doctors, lawyers, and pharmacists came to the conclusion already that the sale and possession of syringes in the state do not require a prescription, for those reasons already stated. For instance, and please don't quote me, but I believe the year before deregulation of syringes, there was approximately 100 needle sticks for our law enforcement officers when they had to reach into purses, pockets, under car seats, and get pricked. They are taken off the line of duty. They have to be tested. Lord knows if they did get infected. After the deregulation of syringes, I think there was 9. needle sticks. I cannot speak to the spread of the diseases throughout the state because I do not have information on that. Now, just by chance, a year ago, a good friend of mine asked me to pick up some syringes. He's a diabetic. I guess he orders the syringes online. He's running low. Asked me to pick some up. I told him I can't do it. I don't have a prescription. He said, you do not need one. So I went to a pharmacy, and I was denied because I lacked a prescription for insulin. Now, maybe it's my legal training in law school. I researched this a little bit, and I found that I do not need a prescription. But the North Carolina Board of Pharmacy has led the way in stating that, somewhere, I believe I read it, that pharmacists have discretion on anything on their side of that bar, which I get. I think they should have discretion. I think it's the right thing to do. But there's also a time when you had to go to the same pharmacist to buy condoms. Now you can buy them on the other side of that bar. For the similar reasons. People thought, well, the sale of condoms would, or the regulating condoms would keep people from getting pregnant. They found otherwise, that deregulating condoms, you have a diminished out-of-wedlock pregnancies, and you have a vast decrease in the spread of noxious diseases. You have the same thing with syringes. Now, on my own, over the past year, I went to pharmacists. I dropped my 11-year-old daughter with me for training purposes to at least look at something in the eye and call it for what it is. 50% of all the pharmacists I went to denied me the sale of syringes because I did not have a prescription for insulin. Now, this North Carolina legislature deregulated the sales and possession of syringes because they were looking out for the health, safety, and welfare of the state of people of North Carolina. And I believe the North Carolina Board of Pharmacy needs to do the same. In my humble opinion, I believe this board needs to make a statement loud and clear. Either you are for the health and safety of not only the people of North Carolina, but our law enforcement officers by taking a stance. Either you tell all your pharmacists, your board certified pharmacists, that they need to be able to sell syringes without a prescription. And it does not violate what you're looking for in terms of their control of everything that on their side of the bar. Or at least educate them. I think it's your duty. And there's no gray area here. You're either for or you're against the health, safety, and welfare of the people of North Carolina on this issue. Thank you for the opportunity to speak today.
Thanks, John. Any questions from the board? No, I don't have any additional comment. I state the obvious. John is absolutely correct that North Carolina is a state that does not require a prescription for syringes, but there is no statute or rule, or frankly, this would be up to the General Assembly if they wanted to make that the law. There's nothing in the law that requires a pharmacist to do. And John is right. Pharmacists set different policies based on their particular practice preferences and assessments, as they are able to do under the law. We don't have any means to force those sorts of sales. And I didn't hear John saying that he was asking the board to do that. I hear John, and John can certainly correct me, making a concern that it may be that pharmacists don't understand that the law doesn't require a prescription on that. I think we have an FAQ on that. As I'm sitting here, I'm not positive about that, but I certainly don't have any objection from a staff perspective from making it very clear in the FAQs and the like that this is what the law is with respect to selling syringes. They're not required to have a prescription.
Right.
And
if I may, I think what needs to be said here is that it's not a legal issue in that respect. I'm talking about health, safety, and welfare of the people of North Carolina. You need to make a position on this, a position statement as a board to say, look, although you have discretion here, you have to keep in mind that the sale of syringes to everyone promotes the health and safety and welfare of the people in North Carolina. Further, there's other issues here you can get into. You get biased. A black man, disheveled black man comes into the pharmacy to buy syringes. Black people have a higher propensity for diabetes. And he's denied because he has a prescription with him. But then you have a nice, really well-dressed frat guy from at UNC Chapel Hill goes in there. He's popping heroin into his blood, but he gets the syringes because he looks the part. There's all kinds of things going on here, and I think that the pharmacists in this state really have to coalesce. This board is the leadership position. It's your position here as a board. You need to take a position here. You can't sit by and say, well, it's something we really get into. We got more fish to fry. No. One person getting infected from diseases due to reuse of syringes, where do we stop? Is it 1? Do we need 5? Need 10? I think it's 1. I think I said my piece here. I think the board understands where I'm coming from, and I appreciate the opportunity. I do have to get back to work. I took my time off here to come for something here I felt very passionately about.
John, we do appreciate it. Appreciate you staying in contact with me. And again, my apologies for the prior screw up on my end about the scheduling, but appreciate your sticking with it on that.
Yeah, I'd like to look forward to whatever official response the board may have.
Very good.
Right.
Thank you, John.
Can I ask you a couple questions?
Sure.
If you certainly may have.
Been here this long. So, are you an insulin user? I mean, I'm just trying to figure out.
No,
the
I'm not.
circumstances.
I don't use needles for any reason whatsoever. And that's part of the thing here is the perceptions here is I am somehow, some way. I really don't even know how to use a hypodermic needle.
Did I hear you say that you went to get them for a friend?
Yeah.
Okay.
He was low on syringes. He was sick. His car wasn't working. I think every one of us has a tragedy case in our lives. You know, people we know that we try to help.
How many pharmacies did you sample to try to obtain syringes?
I believe it was around 10. I really don't want to spend a lot of time on it, but I think it was close to 10, and approximately 50% of the pharmacists. And what they do is say, well, we need to have a prescription so we can advise you on the right syringe to get. I mean, that's all smoke and mirrors. They just don't want to sell anybody any syringes. It's a lot of it is the pharmacist frankly feels they have power and control over everything on this side without understanding the reality of the situation here, that people do need syringes for whatever reasons. Even if it's using illegal drugs, there's a purpose why the legislature deregulated it.
Question, when was that done by the legislature?
I do not recall, sir, but I believe it's
Last few years?
I believe it's around 2 years ago.
I don't know. It's never been the law since I've been here that I can remember that North Carolina required prescription for syringes.
Well, actually, no, sir. The North Carolina statute at some point scheduled syringes as paraphernalia, and that was removed. The word syringes was removed from that portion of the law through an amendment, I guess, of the legislature. And also, there's an additional law which allows people to declare that they have syringes on their possession when they're pulled over by a law enforcement officer in order to protect the law enforcement officer from getting needle sticks. And that was recently passed, I think, 2 years ago.
Any other questions from the board? So we appreciate your time.
You got it.
Come and talk to us. Have a good day, sir.
You as well.
Thank you for
Hey, John.
coming in.
Take care.
Mr. Campbell?
Next item on the agenda, Mr. President, just an update issue. You all saw the letter. I just wanted to confirm it on the record here. The General Assembly passed a statute asking the boards to make sure that to the maximum extent possible that your license requirements correlate with military training and experience. This was an amendment to a statute that was passed in 2012. Demanded of each board that by September 1st, each licensing board submit a report to a joint legislative research commission concerning those matters. You have behind your tab a copy of the letter, which you have already seen and approved. I just wanted to report that that I have gotten specific acknowledgement of the receipt and appreciation of the receipt of that letter. There is nothing further that I'm aware of that we need to do. I have given the appropriate documents to Glenn Batten, who's the Deputy Director of the North Carolina Division of Veterans Affairs, to post on his website. To the extent there was anything, I guess, interesting about the process, it was that my sense is that virtually all licensing boards had no idea they had to file this report until an email went out 3 days before it was required to be filed, and so there was some bit of scrambling on that. But we're filed, we're on time, our documents reflect that. I don't think there's anything further that we need to do. Certainly if I get any feedback indicating that we do have further work to do, I will advise you immediately and start with that.
Okay.
Next item on the agenda is Debbie in here. Yeah, there's Debbie. You have a note behind your tab, and this is concerning pharmacy technician students present in pharmacies as part of an experiential education program. And Debbie can help out and chime in. But Debbie's getting a lot of questions about this, and isn't that right, Debbie? I mean, you're getting it probably about once a week is getting a question. And you guys are aware certainly that a component of, especially the community college-based technician training programs, includes an experiential component. And we have for a long time gotten calls from pharmacists that say, I've got technicians from Durham Tech or wherever it is who are doing this program. They're in my pharmacy. What do I need to do in terms of registration? Several years ago, we kind of dealt with this issue in that the board approved a guidance statement concerning whether technicians present in a pharmacy as part of an educational program, do they count toward the pharmacy tech ratio? And I've reproduced that Q&A here, and that's just a verbatim copy of what the board approved. I think this is probably 2009 or 10. And I'll read it. Students currently enrolled in a community college-based technician training program typically spend some time at pharmacy practice sites as part of their education. Such students present in a pharmacy solely for such students present in a pharmacy solely for educational purposes as part of the technician training curriculum do not count toward the permissible pharmacist technician ratio. The board emphasizes, however, that the student must be present in the pharmacy solely for educational purposes. A student who is employed by a pharmacy as a technician does count toward the permissible pharmacist technician ratio, notwithstanding that the student is also enrolled in a community college-based training program. The upshot of that is I think a lot of folks have, in my opinion, reasonably read that as saying, well, if they're not employed by us, they're solely for educational purposes and they don't count for the ratio, they don't need to be registered with us. But it's not clear. Or not absolutely clear, or at least not clear enough to spare Debbie calls every week or two on the issue. And so what's before the board, I guess, is to ask what's your pleasure on this? And if we need to take time, we can take time, and Debbie can keep filling in the calls. But could be just a matter of a clarifying sentence, a clarifying statement in the Q&A that just says all these qualifiers that are solely in an educational capacity, 9 point, et cetera, just clarify that they do not have to be registered and do not count toward the technician ratio. That's a clean solution to it. I think implicitly that's what it already says. But we're here to present this to you for your thoughts on that, and Debbie may have additional or different thoughts on it, but
Pleasure of the board. I think your comment is all needs to be taken care of.
Well, I will say that when this came up before about the ratio stuff, the feeling of the board was, look, if technician programs include an experiential component, that can only be a good thing, right, ultimately to the public health and safety. And so the sense was there, let's not disincent pharmacies from acting as training sites because now all of a sudden they're above the ratio or whatever. It seems to me that rationale still will apply here, as long as it's purely educational. I mean, look, is it possible somebody will try to get cute with that? Yeah, it's possible, but we find that kind of thing on inspections when we do them. So,
okay.
But if that's the will of the board, we need a motion if it's just the sense of the board to make an edit to the FAQ to clarify that point.
Well, board members comfortable making the change in the FAQ?
So under the answer part, is it only the first paragraph that's in the FAQ?
Yes, I'm sorry, Bill, that's not clear. Yes, it's only the paragraph that begins "a period." The next paragraph that begins, that guidance at least implicitly suggests that was simply my staff note to the board members. I apologize, I should have made that clearer.
Do we need a motion?
No, don't.
I think it was
This
just a
is
sense of the
consensus of the board. Everybody comfortable with that?
Please clarify that, Mr. Campbell.
So what I am proposing is that we simply make an edit to the existing FAQ that will say such students present in a pharmacy solely for educational purposes as part of the technician training curriculum do not have to register with the board as a technician and do not count toward the permissible pharmacist technician ratio. That's it. About a 5-word edit. Some of you in your practice sites may have some of these students.
We have them all the time at
Yeah,
our
that's-
store.
Yeah.
Been 4 or 5 years.
Right.
Bill, you comfortable with that? Okay. All right, Mr. Campbell.
Since the board, so it will be done, and Debbie will, you and I can talk about sending that out maybe to the pharmacist managers to make that clear. Next item on the agenda, we need Gail. There's Gail. Come on up, Gail. We have the general financial report that you get at every meeting. And also before you today is a request for approval of the fiscal year 2014 budget. To report to the full board, the finance committee of the board, which was Mr. McLaughlin, Dr. Chesson, and Ms. Day, met here at the board on, I think it was August 26th, and met with me, with Gail, with Rhonda, and we went, and Ellen, and we went through a line-by-line review. Carol, was it everything you hoped it would be through that process? Went through a line-by-line review of the entire budget, and what is presented before you for your consideration is the budget as approved by the Budget Committee after some adjustments that were discussed during the meeting. So, Gail, why don't you give the general update, financial update, and then you can open it up for any questions that the members may have about the budget proposal itself.
Okay. Under your financial tab, the first is the letter to Mr. Campbell, the memo summarizing our August activity. Your next report is the balance sheet and lines.
Can I ask you a question? Just could at some point in time, could you kind of give me asset allocation of your long-term investments?
Sure.
Do you get that?
Oh, yeah,
routinely?
we got a detailed statement of that.
Yeah.
And we discussed it in the finance committee. I mean, the reality is that virtually all of that is in CDs pursuant to. We have just to back up, the board passed and approved an investment policy. Parker, what was that now, 5 or 6 years ago?
At least.
And that largely tracks the investment requirements for the state treasurer for certain things. It tracks the statute. Very conservative, obviously, and as a practical matter, given bond yields and the like, pretty much everything we've got these days has been in CDs, and so we're not exactly making.
I just want to see the asset allocation.
Yeah, we can get that for you.
Okay, sure.
Yep.
Thank you.
We'll get that to you.
Thank you.
Yeah, and so on the balance sheet, line 6, our total cash is $6.578 million, and our total assets is $8.3 million. Our line 44, our excess revenues over expenditures for the fiscal year is $920,416. Our total fund balance is $8.18 million, and total liabilities and fund balance is $8.3 million. If you look at line 2 under cash assets, our the total in the First Citizens money market, the $2.364 million, we would like to transfer $1 million of that into our 2 long-term investment accounts with First Citizens Bank and RBC, and that would be $500,000 into each one of those. So today, whenever, if you want to approve that, just whenever you approve these financials, we'll approve that also and get that done before the end of the fiscal year. The next report is the profit and loss for August, which is 11 months into our fiscal year, we just have one more month. Line 25, our total revenues is $3.89 million. Our budget was $3.84 million, so at the end of August, we're $51,889 over our budget, for revenues. And we just had reciprocity yesterday, and I think there were 40.
It was a packed house.
Yeah. 47, so we definitely are going to be over on our revenues for the fiscal year. For expenditures, line 79, our actual expenditures at the end of August for the fiscal year is $2.94 million. The annual budget through September is $3.44 million. So currently, we are $469,294 under budget. Our total excess revenues over expenditures for the fiscal year is $920,416, and our cash balance at the end, line 86, at the end of August is $6,590,000.
And just a reminder, that's 11 months. Obviously, that's excess revenue over expenditure figure is going to shrink between now and the end of the fiscal year.
And some of our expenditures that will that are under budget for the fiscal year will be salaries and our hospital insurance, professional meetings, board members, our building expense, executive director's expense, consulting, and legal fees. And even though we still have one more month, we'll still be under budget on those line items. The two items that, the variances that are somewhat large for being over budget on expenditures was overtime and vacation pay, and the overtime was due to the increased inspections and the deadline that had to be met for completing those in March of this year. And then our vacation pay, we never know who's going to retire sometimes during the year, so that's why that number is high. Now, if you'll look at the last column of the financials, which is our proposed annual budget for 2015. And do you want to talk about this, Jay, or any minute?
Well, yeah, what I would say is that I think you're all familiar with the process that we undergo to project the budget. Gail and Rhonda spend a lot of time going through each and every line item and calculating our anticipated revenue, which is, fortunately, tends to be very, very predictable. That has been done. That has been explained in detail to the Finance Committee, the methodology. You'll see we're forecasting a very modest increase in revenue next year, which would be what you expect since we have fixed fees for things. And then with expenses, you'll see also that we've gone through and budgeted based primarily on historic data. The salary projection, there's a cost of living increase of 1.5%, and then a committee approved 1% additional bonus for not bonus, 1% increase in salary for staff. There have been reductions in some expenditure items, including my expense line, that I voluntarily did that to make sure that money was being used as it should be used. And you see our total expenditures budgeted going into next year in all the same categories we got. We anticipate we'll have a very slight decrease in our expenditures next year, fairly well commensurate with the slight increase in revenue. We're happy to talk about any individual line items that you would like to talk about. And the Finance Committee has gone through these with a fine-tooth comb, but happy to answer any questions. We did get good news on our health insurance this year. We're actually getting a slightly better plan at like a 1% increase of our costs. So we did well with that this year. And that is to Gail and Rhonda's credit for going out aggressively in the market and seeing what we have available to us. There's also been a substantial decrease in our dental insurance for employees based on Rhonda and Gail shopping around that coverage. So there you have it. There's nothing in the expenses that we've budgeted for next year that are, in my opinion, a substantial variation one way or the other from prior years, but happy to talk about any or all of them as you would like.
Do any of the board members have any questions about the proposed budget, Ms. Gale or Jay?
And we are certainly indebted, Joanne Parker and Carol, for the amount of time you've spent going through this. It's not glamorous, but it's incredibly important, and your input was very, very valuable to the end product here.
Do you need a motion to approve the
We
proposed
would
budget?
if it's the will of the board, I would ask for a motion to approve the fiscal year 2014-15 budget, as well as approving the transfer of $1 million from our cash into our long-term investment accounts.
May I have a pleasure of the board?
I move we adopt that.
I'll second that motion.
All in favor?
Second.
Aye.
Aye.
Motion carries. Jay, again, I'd like to thank you for the job of running such a smooth ship. Ms. Gale, for your work you do is impeccable. Your report,
Impeccable is exactly right.
yep. And if you ever decide you want to change jobs, I got a job for you.
We'll have to arm ourselves.
We'll move you to the east.
Gail, thank you, and thanks to Rhonda as well, and to all, and look, all the directors here take this very, very seriously, and I think the financial performance over time reflects that.
Absolutely. Commend
Thank you,
all of
Gail.
y'all.
Yeah, I'd just like to thank everyone too, the board as members and staff, because it's, and our director, because it's a joint effort to keep our cost and everything in line with our budget.
Yep. Thank you very much.
That's important. Thank you.
Mr. Campbell?
It is 11:30. I know that Wendy Cox from Carolina emailed and let us know she couldn't be here. Is anybody here from Campbell or Wingate? We had not heard, okay. Then I would suggest, Mr. President, I think we can probably move on through the remainder of the agenda items that we have in the time.
Yes.
That we otherwise
I would like that, please.
Wanted to give a brief report, as certainly the board members are aware, the Program Evaluation Division of the Legislature is in the meaty part of its study of the occupational licensing boards as directed by the General Assembly. Mr. McLaughlin, Clint, me, Gail,
Debbie,
Josh, Debbie, and a cast of thousands. We went over to the Program Evaluation Division 2 weeks ago to meet with Chuck Heffron, who is leading that study. I just wanted to report to the board that there sort of a major theme that is developing, and this ties into the next agenda item, so I'll just sort of combine those, is it was clear that the Program Evaluation Division thinks that that some level of additional oversight of the boards, the occupational licensing boards, is needed, and they are pointing to the state auditor's report of a couple of weeks ago that criticized, in large part criticized other state agencies for not paying attention to the reports that occupational licensing boards file, but also criticized some licensing boards for not conducting training and not filing their annual reports and the like. We, of course, do file all our reports and do all of our training. And I think Gail could tell you if I'm wrong, to the extent we were mentioned in the auditor's report, it was in a positive way for what we do, particularly with our financial management. But there did seem to be a recognition among the PED staff that there's a distinction between boards like ours that are structurally and fiscally capable of carrying out a regulatory mission versus some boards that sort of fiscally aren't able to carry out their mission because of either lack of licensing revenue or lack of resources or whatever they may be, and we certainly detected a great deal of concern about whether and how those agencies can carry out their mission. There was a lot of spitballing of ideas about consolidated IT issues. We certainly communicated to Mr. Heffron that if we were forced in any sort of centralized IT, it would require the loss of literally millions of dollars in development of our IT resources. And he did seem to understand that. There was also, there seems to be some interest among the PED staff in a body in Texas called the Texas Healthcare Commission. Is that what it's called?
Something like that.
Yeah, Texas Healthcare Council, which is not an umbrella structure per se. The membership of that in Texas is made up of each of the health-related occupational licensing boards, each of whom contribute some amount of money, I think on a per licensee capita basis, to fund this council. And Clint and I have been reviewing documents on that council and what it does. And that council, as it's comprised in Texas, really seems to act at the behest of the boards, not vice versa. But that council exists to help come up with cross-training that might be helpful to maybe develop IT resources for boards that can't otherwise afford them, and otherwise sort of seek avenues for cooperation and improved efficiency. But we didn't really get anything more from PED about their vision for what that might be. So I guess from my standpoint, where I leave is could have been a lot more frightening visit, I suppose. I'm not going to lie to you and say I walked away with a great deal of comfort either. But the study proceeds apace, and we are expecting to get a draft of the study report in November. I think end of October, early November. At which point we will certainly need to convene and discuss what response, if any, we want to make to that. But that's the lay of the land. I don't know if you have anything to add on that.
I mentioned to for the board members' information, I was present for that. I want to commend Jay and Clint. They did a remarkable job of answering all the questions that he had for us. Well, what do you do on this case, or who oversees this? And I thought our board and our council did a fantastic job. We had an answer that was clear cut to every question he asked us.
I got a sense that, and I don't know, but I got a sense that maybe a great deal of what that body has been looking at are the very, very small boards.
Yep.
And I got a sense that maybe they were drawing conclusions from that sample that really aren't applicable to us. And like it was surprising to me that they were surprised that we said things like, yes, we assign a number to every complaint that comes in and we track it through the process and we respond and do all this. I think they've met with some licensing boards that don't do that. Not necessarily because they don't want to, but they can't. And so it was certainly an opportunity for us to show we're doing the right things.
I agree with that, because I thought the same thing I was telling Clint earlier, is they were surprised that we had all the positions and data in place to answer every question he had. And I think he was taking back a few things, trying to find something else, and we countered that with, yes, we do this and this. So I commend y'all and your staff.
In fact, one of the staff members ran down the street to chase us for an example of how we logged complaints, but it was different.
And we were able, thanks to Cindy Pierham's incredibly hard and last minute work, I was able to say, there it is.
Yep.
So I think we did acquit ourselves well. The question with these sorts of studies is, of course, whether and to what extent any of that matters, and we will find out in due course. So obviously, anytime I hear something, I'm letting you guys know.
Did you say they called that meeting or you called it?
When we filed that survey, remember we had that big survey response, and one of the questions on the survey was, would you like to meet with the program evaluator? And I think that PED was surprised, although I don't know why they should have been, but I think virtually every board said, yes, we would like to meet with you, because as you can appreciate, I think they did the best they could in trying to create this survey document, but I also think that they pretty quickly came to a realization that this survey was not going to be the tool to allow apples to apples comparisons that they had hoped it would be. So it was nice. I think we all wanted to take advantage. Look, we responded to the survey assuming that that might be the only opportunity we had to tell our story. But they offered to let us go further. We took advantage. I think virtually all boards did. And I did get the sense they appreciated that. I did not get any sense that they didn't like that we were there or weren't interested in what we had to say. But I think Chuck has had to schedule a lot more meetings than he thought he was going to have to schedule as a result. It was not antagonistic. I did not think it was an antagonistic meeting. I think they have thoughts. We had thoughts. It seemed open.
Well, I would say my general sense was that he was tossing ideas off of us as a board that had thought about things and that could give him helpful thoughts on his spitball.
How many boards are there? How many occupational licenses?
There are. Well, that's the audit report makes this point. There's apparently some debate as to whether there are 55 or 57, and it apparently depends on who you ask that question to. But I had always heard the 57 number. And there is a list. If you look, I think in that audit report, it does have a list of all of those.
Were you able to hear anybody else's presentation?
No, these were individual meetings. I assume, well, I shouldn't say that. If PED follows, if the process follows the one that was used for the prescription drug diversion study they did, they will draft a report. They will go out to all of the boards who can comment on the report, and they can accept or decline those comments and suggestions as they see fit. It will then be reported to the Joint Legislative, I think, Program Evaluation Committee on, I don't know, there's a lot of those over there, and I'm going to goof up the particular name, and they will present that to that committee. Usually there are representatives from the bodies that were part of that study that were there. As to how much opportunity you have to comment at a committee hearing, that's entirely at the discretion of the chair. The prescription drug diversion chair, there was not a lot of comment expected on that. I expect there are going to be more people who want to comment on this one in the public forum. We'll just have to see what their tolerance for that is. And then usually what comes out of those meetings is there will be some directive from the committee to draft legislation addressing X or Y, and I think I certainly think we can expect there's going to be some legislation that appears in January at the next long session concerning occupational licensing boards. What form it takes at this point, who knows? And that is, Mr. President, that is that state audit report. I don't have anything to add to what I've already said with that. You've got a copy of it there for your nightstand reading enjoyment.
Next item.
Next item, just a reminder about the board retreat. You've got a schedule there, but just a reminder, it's Thursday, October 2nd. At Proximity, we're going to convene at 11 a.m., and that should say convene, not convene. It's my fault. I don't know what a convene is. But remember, the first thing we'll be doing is we're due for our every 2-year inoculation of Open Meetings Act and Public Records Act and State Tort Claims Act and EIEIO. So we'll be doing that at 11. We've sort of had just a reminder how incredibly important it is that we get that caught up. I know that at least one board member is likely to dial in, and we'll have that set, and that's fine. We can accomplish that, and we'll get that taken care of. We'll have lunch after that, and then the items you see after that are the agenda items that you guys have submitted over the year, and then we convene for dinner at 7 p.m. for the Leaders Forum dinner. So, Joey, I appreciate your working with me on that schedule, and looking forward to the retreat.
Okay.
Multigon, just a reminder, the Multigon Conference is coming up in St. Petersburg, Florida, October 26th through the 29th. I am not able to attend that. That overlaps with the North Carolina Association of Pharmacists annual meeting. So I'm attending that. But Ellen is going to be going, Crystal is going, and I think at least one more inspector. Cindy going? Yep. Oh, that's right. You got some politics to do. So we're going to have a presence there. But any board member who wishes to attend Maltagon, be sure to touch base with Cindy, and we'll get you registered and help you make all the arrangements. For those, I think everybody here now is familiar with Maltagon, but it's Carmen Catazone jokingly calls it the Confederate NABP, but it's a looser grouping of states, and the focus tends to be the focus is somewhat on policy issues, but it's really more on the practical day-to-day issues, how our board's dealing with specific issues that are in front of us. And it's particularly been useful, I think, over the years for the investigative staff to interact with their colleagues in other states. So we'll continue that involvement. But it's coming up, so if you'd like to go, get in touch with Cindy.
Has the agenda been sent, Cindy?
I think it just came out. I think I got an email literally last night from Malcolm. Did you get that?
Oh, I only got a preemptive agenda, but I haven't seen the registration or anything.
Okay.
I've got it.
So we'll send that
And
out.
we're still having the board meeting on the 21st of October.
That's the third Tuesday, right?
Yes.
Yep, and that's when we'll have it. And that, investigative, sorry, Josh, I was about to cut you out from your investigative statistics class, but if you have any questions about any of that, I'm really happy to answer them, but Josh can give the investigations update.
All right, well, as usual, we're still rolling right along. We got all of the positions filled, thank goodness. So hopefully.
May they stay that way.
Yeah, may they stay that way for a while. I don't feel like doing any more interviews. Anyway, you see complaints as of the 12th, we were at 166. Our procedural, legal, and then errors are still our top 1 and 2. Diversion, is a close third with 33. And the surrenders, we are up to 30 so far this year. 17 techs, 4 pharmacies, and 9 pharmacists. So, again, having full staff, should help with case distribution and not having to call in other folks from other territories to come in to handle other cases. So, and
the inspectors are working incredibly hard as we've been trying, and they're still keeping up with the inspection. The one thing just to be aware of is that we are getting our baseline inspections completed for each DME facility in the state. We have extended that deadline slightly for the investigators. We're still going to have that done before the end of the year, but there was a need for a little pressure relief valve on some of that, particularly with new personnel coming in, but we will still have that done. So if and when there's a return visit in the spring from the state auditor's office, we certainly will have completed each and every one of these inspections and gotten them done. So.
Yeah.
Thank you, Josh. Very
All righty.
Mr. President, I don't have anything further for the board. The consent agenda certainly remains. But that covers all the items.
I got a question about that. You have a consent order. Is that a staff consent?
I'm sorry, Mr. Menton, let me explain that. There's a consent order of discipline that you have before you concerning Richard Harris, a pharmacist with a license. The sort of backdrop on that is Mr. Harris had an alcohol abuse issue. He never surrendered his license, but he with the assurance of his attorney, stopped practicing pharmacy, and in fact has not practiced pharmacy for 14 months. And PRN supported him because it was not a reinstatement staff and Mr. Harris at PRN, we met and discussed a proposed consent order of discipline on his license. We presented that to Mr. Mixon yesterday at a pre-hearing conference since it wasn't a full-on reinstatement. So thank you for pointing that out, Mr. Min. It's a little bit of a unusual, I don't know if unusual, but just different from the run of the mine.
I think it's fine. I
Kind
just-
of thing, right? Yeah, but no, I'm glad you asked, because that's why that's there. Don't, as you well know, full-on reinstatement hearings we bring before the full board. Since that wasn't this, we took it before. But certainly happy to answer any questions about that consent order of discipline. We presented it to Mr. Mixon, and he was in agreement that that was an appropriate resolution of this case.
You still need to have a motion to approve that consent order, correct?
Yeah, we certainly would need to have a motion to approve the consent agenda. But yes, part of that would be the board ratifying the consent order. It has simply been recommended to the full board for disposition. It's
Okay.
not.
I move at the time that we approve the consent agenda.
I'm have a second.
I second that motion.
All in favor?
Aye.
Motion carries. Mr. Kimmel, that concludes that consent agenda.
Is that something that I vote on since I heard them?
No. Let the record reflect that you did not vote on the Richard Harris consent order, as you had recommended it to the board. I do want to make one additional announcement, and hopefully you guys saw it. Ellen Vick, our intrepid Associate Executive Director, has been accepted into the Leadership North Carolina program, and I don't know how many of you are familiar with that program. Parker, I imagine you are.
Yeah.
But they accept roughly 50 people around the state each and every year, and it's an intensive development of leadership qualities, networking. Ellen can describe it better, because I think Brian Vick also completed the same program, but I was proud to be one of Ellen's recommenders, and am very proud that she was accepted in that program, both for her personally and also for this board, because that kind of program leads to the kinds of connections, leadership skills, et cetera, that tend to prove very valuable to the organizations that send representatives to that. So this is a big deal. So congratulate Ellen on that.
Congratulations, Ellen.
Thank you.
Very good.
That's all I got, Mr. President.
Our board members, I see that our agenda has been taken care of. Do I have a motion to adjourn?
Oh, we do have a summer suspension. Okay, sorry about that. We do need a closed session.
Closed session. At this time, I have a motion to go into closed session.
So moved. Second.
Second. All in favor? Aye. If y'all just excuse us a while, we'll be done in a little while.
Is that the North Carolina
Second, all in favor? Aye. Do I have a motion for adjournment?
No, I think we should sit here.
I move we adjourn and have lunch.
Second,
Second.
all in favor? Thank you all very much. Thank you for the staff today.
I will this afternoon, I will draft up a summary of the comments and stuff that we got on the rules and go ahead. I want Clint to look at it too, because we need a summary of the comments and sort of the procedural stuff, and I'll have that to you guys before the end of this week.
Okay. Thank you for today.
Yep, thank you guys.
Miss Cindy, what do we have today? Oh, potluck.
Barbecue. Chicken.
Middle Eastern.
No.
I gotta put it
No. Lord, I'll be going to Hardee's.
We're going to Hardee's.
Thick burgers all around.
You must not have to eat those every day.
No, I don't.
Get out, I mean, you get out.
And we're having, Joey, we're doing tofu fondue, so we can all gather around the,
Take care of yourself.
Board meeting
How
was
about that?
convened, or deconvened, I reckon. What's going on?
This thing got that circle
Oh my
going
gosh, I
on
don't have time for raps
I
today.
can't get it.
Can I call you next week?
snacks.
Yeah.
Don't
Okay.
force me.